So I apologize. I'm wearing a lavalier because I'm a little bit manic and I can't sit in one spot. It's always been a problem for me. I'm going to talk a little bit about South Florida experience. And I got to say, after listening to Dr. McTaggart, he's already my hero because he espouses a lot of the ideas that we espouse in South Florida. A little intimidating for me to be up here, all you really, really smart people. Especially being in EMS, we're just a bunch of truck drivers that you all have been talking about all day. And then I saw that picture of our award winner driving the plumbing truck, and I realized you guys are just plumbers. So it's probably not too far off. I do have disclosure, and the big disclosure I've got is that it makes no difference to me financially where patients go. That's when they're having a stroke. It makes no difference where they go with whatever condition they've got, but especially for stroke. And stroke's big business. And business and politics do play a big role in this. And one of the lessons I'm going to talk about is that it can be uncomfortable when we talk about this. And it's often the elephant in the room, but we really need to handle this head on for the interest of our patients. And just a quick case study. Let's see if I can get that to come up here. There we go. So this was an elderly woman, large vessel stroke. She had contraindications for TPA and she was not at a comprehensive stroke center, ended up having a large vessel stroke and passed away from that. And you see that there's a difference in outcomes for our patients. Had she been at a comprehensive, it might have been a different story. So a couple of questions I want to try to answer when I'm up here from an EMS perspective is, what's the best transport model? Should we do the spoke and hub that's been in the literature in the past, or should we go straight to comprehensive? And how does the business and politics of stroke interact with medicine? All right, so here's our stroke center history. You know, back in 2002, we had no stroke centers whatsoever. And then the first one popped up. And that was great. We finally have somebody that's starting to do strokes care. And then the next one popped up. If I can get this thing to work here. There you go. Then we had another, and another, and another, and another, and then every single hospital in our county, except for our one little rural hospital, became a stroke center. And we looked at that, and we have a term in EMS that we use. It's called regionalization. And what regionalization is when you take high acuity, low frequency cases, and you concentrate them in a few hands, outcomes get better. And the first example of that was really the trauma centers. And that's where we drive past lots of other hospitals to bring these cases to specialized center. And a genius once said that when everybody is super, then no one will be super. And you guys know who said that? That's right. It was the evil genius Sinestro from The Incredibles that came up with that. And it's actually pretty sage advice, because what we're seeing here is this propagation of stroke centers all over the place. And is it really in our patients' best interest that we're not concentrating these cases in select hands? Because that's the opposite of regionalization. We know regionalization actually works. So brain catheterization really made the big, I don't tell you guys, you're all expert on this. This is what has really made an enormous impact in this particular disease. And really, I gotta give you guys are all my hero here for dealing with this. And for so many years, we would have a stroke patient come in the ER and we'd say, oh, that's terrible. And we'd stick them off the corner, there's nothing we can do. But this has really been a true revolution in healthcare, that you guys can open up these vessels for these people. But the bottom line is Roto-Rooter beats Drano, right? Every single time. That's why I got the Roto-Rooter truck going real fast there. And that's what we know, that simple plumbing and large clogs need Roto-Rooter. And that's what we found from Mr. Clean. So when you look at, if you're the patient, I want you to look at this as if you or your family member is the patient. And look at this list. And you tell me, from EMS standpoint, where do you want me to take you? Right? Do you want me to take you to the place that can deal with the small vessel stroke and nothing else? Or do you want me to take you to one-stop shopping? It doesn't matter what you've got. It could be a bleed, not a bleed, it could be a large vessel, it could be small. It makes no difference. So it looks kind of obvious to me where I'd want to go. If you're being honest, I think it's probably obvious to most of the people in the audience as well. So here's our spoke and hub model. And this is what we were doing for a long time. EMS would just take you to the closest hospital, whatever that was. And most of the time, that was a primary stroke center. And if you were bad, they would transfer you from the primary to the comprehensive. And we already know, we saw the Rhode Island data, that causes tremendous delay when you go. And then in 2013 and 2015, recommendations came out from the American Stroke Association that said, you know what? When EMS, like we have in Palm Beach County, by the way, what I'm talking about, this is not necessarily translatable all over the place. This is really local resource dependent stuff. But we have a lot of stroke centers, and we have a fair amount of comprehensive stroke centers. And what they came out and said in 2013, and then they went double down on 2015 because of the endovascular studies, is that when EMS is faced with multiple stroke centers, you should go to the highest level of care that you can get to within 20 minutes. Within an extra 20 minutes is what they said. So based on that, we looked at the model of bypassing all of the primary stroke centers and going straight to comprehensive. Unless you were at one of the places that was sort of in our rural area where the comprehensive was so far, we would still go straight to a primary because it took too long to travel to comprehensive. So that's the model that we sort of embraced. And I got all of the primary stroke center CEOs together in one room because I figured this will be efficient. I'll just get all the hospital leadership in one room together with me. I'm going to tell you the story. And I'm going to tell them, guys, I got good news. This interventional stuff is the real deal. And EMS now, we just want to do what's right for the patient. So the good news is we're going to drive past you now and go straight to comprehensive. And I think I have a picture of the meeting actually here. Yeah. So, and I'll true story here. I had a bunch of my EMS leadership there with me. Not one of them sat next to me. I was like, guys, why don't you sit next to me? And they go, we don't want to be collateral damage if they're a bad shot. So it got a little heated in that room. And then I turned to the hospital CEOs of the comprehensive. I figured at least they'll be happy. I was like, guys, you're going to speak up for me, right? Not a word. Not a word from them. So then I looked at the aftermath of this. And this was 2015 that we did this. And we got predictable complaints to the fire chief. And then when the fire chief said, listen, our medical director makes the choice on this, we got predictable complaints to the county board of commissioners, which is the fire chief's boss. And then what I didn't predict was that we got complaints from the Chamber of Commerce. I was like, what do you guys know about stroke? And that's how I realized they don't know about stroke, but they know about business. And that's why I was like, aha, so this isn't really about medicine, it's about business. And unfortunately, and I lament the fact that doctors and nurses and others in healthcare, we've lost control of healthcare to the businessmen a long time ago, and we have to keep bringing the center back. We are in an industry that exists for the good of humanity and nothing else. That is the one and only mission we've got. And when we keep coming back to that, things become far more obvious. We stop worrying about people playing in each other's sandbox. So I had three major complaints, three major things that folks were telling me that why I'm doing the wrong thing. The first was, well, you're just misreading the American Stroke Association policy. You're going to overwhelm the comprehensives. And you know what? By delaying TPA, by driving past us to go to the comprehensive, you're killing 1.9 million brain cells per minute. So I'm a reasonable guy. I said, all right, I'm going to look at each of these complaints, and I'm going to see if I'm wrong. So I called up Dr. Higashida. I called up Dr. Durding. Those were the chairman and vice chairman, respectively, of those two things. I said, gentlemen, I am in a county of 1.5 million people. And that's a lot of people to be responsible for. And I have to make the decision on where I take these folks. And I want to make sure I understand what your recommendation is. I'm going to give you a scenario. I have your family member in my EMS vehicle with me. I am 1 minute away from a primary stroke center. I am 19 minutes away from a comprehensive stroke center. Which direction do I drive? And they both said, drive to the comprehensive. So I said, okay, I understand what you wrote. And then I said, okay, are we going to overwhelm the comprehensives? Now, back at this time, we had 4 comprehensive centers in Palm Beach County for a population of 1.5 million. And we looked, how many strokes do we have per year? How many stroke alerts? 1,800. That turns out to 1.2 stroke alert patients per day. Now, I know when I'm in the ER, I like a slow day, but one patient in 24 hours, I think even any of us can handle. So I was like, okay, I don't think we're really going to overwhelm our comprehensive stroke centers. And in fact, we haven't when you ask them. But this last one was the most important, because this one I was like, am I doing harm from an EMS standpoint by driving past these primaries? 1.9 million brain cells. So we looked at it. And Palm Beach County is a very large landmass. It's actually the largest county east of the Mississippi. But the vast majority of the population is along this eastern corridor where I have the boxes there. And these are our 4 comprehensive stroke centers at the time. Those are all our primary stroke centers. And I said, you know what? Let's look at the north end of the county where if we bypass not 1, not 2, but we bypass 3 primary stroke centers to go to a comprehensive, what happens then? And it turns out that yes, in fact, it takes us extra time to drive. It costs us 10 minutes to drive there. But then the trick of regionalization kicked in, where when you start concentrating these cases in just a few hands, you start getting, I swear it was on mute before I walked up, said, and they got so much faster at the comprehensive that we actually saved 1 minute from 911 to TPA. And by the way, this was back in 2015, and this has gotten dramatically more pronounced since that time. So, okay, I'm not losing time on TPA by doing this. But what about brain cath? Because that's really where it's at. I mean, if you look at it, the vast majority of deaths from stroke is large vessel. The majority of long-term severe disability is large vessel. And TPA fails 90+% in large vessel. So brain cath is really important. So here's our time again, transport. There's our TPA time. And then there's no additional transport time if you're already at the comprehensive. And that's the extra transport time you get when you have to do interfacility. And then you have your door to brain cath time. We were saving an hour and a half from 911 to brain cath. And this is a small internal study, but when I calculate that out, by driving past, I was saving 1.7 billion brain cells using the neurologist's own figures. So now I'm like, okay, we're in EMS. EMS is a simple thing. We know about losing brain cells, right? This is something we do daily as we're training. So I look at this and I was like, okay, I think we're doing the right thing by driving to the right center. So that one's out. So what's happened since then? Well, we started actually looking at this because we did a small internal, that's data I showed you was an internal Palm Beach County Fire Rescue quality control thing. But now we looked at it in the whole South Florida region using, again, that Ralph Sacco's group. And this is a study of 36,000 patients in South Florida that showed the before and after effects of EMS bypassing primary strokes to go to comprehensive. And it showed rates of TPA treatment went up. So far more people were getting TPA. 911 to TPA, that's real time. Boy, I don't know what's going on with this. Sorry, state medical director stuff. It doesn't stop. 911 to IV TPA, that went down. So we're driving all over. We're driving much further. We're getting a lot more people that get TPA, and we're giving TPA a lot faster. Rates of endovascular therapy went way up. And most importantly, the time from 911 endovascular therapy went way, way down, 112 minutes. This is a remarkably stable number, by the way, in the hour and a half to 2 hour range. That's how much time we're saving. And because then you look at the Stratus study. I don't know if you guys are familiar with this data or not. Dr. Mueller down in our part of the world likes to present this data. And it's a similar thing. When you bypass in the Stratus data, you bypass the primary, go straight to comprehensive, your number of excellent outcomes from MRS 0 to 1, that goes up. And the good outcomes, that also goes up. So not only are we saving time, we're now proving that you are improving outcomes for people. For every 1 hour delay in treatment, you had a 5.5% decrease in good outcomes. These delays are really, really critical. EMS stopping a primary stroke center, average delay in Stratus, remember I told you the 112 minutes an hour example? Here it is again, 116 minutes in the Stratus data set. It's a remarkably stable number. But this was the most important thing. The difference, after they controlled for all the variables, the difference in outcome, the good outcomes from going straight to comprehensive, was entirely due to the delays from stopping at a closer primary stroke center. Had nothing to do with anybody being special at one place or another. It was entirely due to delay in treatment. Now we have to talk a little bit about volume, because what we're starting to see is now that we're bypassing primary stroke centers, everybody who are primary is starting to become a comprehensive. And again, this is the reverse of regionalization. It's not really exactly what you want. And this graph kind of shows that what we know, it's just intuitively correct. High volume centers give you better outcomes, right? The more you practice something, the better you get at it, to the point you can do it in your sleep. And a lot of times you poor neurointerventionalists are doing it in your sleep. I apologize for that. So you want somebody that does a lot of these things. And as your volume goes up, your death rate goes down. So to go a little more what we do, I know we talked a little bit about pre-hospital, and Rhode Island's a fantastic model, about using pre-hospital stroke severity scores. And there's a million of them, right? There's the VAN, the LAMS, there's the RACE. We actually do what's called the RACE Plus. But in Palm Beach County and in Broward County, we do not use these pre-hospital stroke scales to decide where we're going, because we always go to comprehensive. If we think you have a stroke, you're going to a comprehensive, period. And if you're in a rural area, we fly you to the comprehensive. That's how we do it now. So why do we even have this? We use this to call our comprehensives and say, you know what? High likelihood you're gonna need the cath lab, you better get it warmed up. And we actually have some of our comprehensive, our interventionalists, have given our EMS folks their cell phone number and say, if they're positive on these scales, in addition to calling the ER, you call me. And then our neurointerventionalists are now getting the ability to use telemedicine and screen these patients and say, you know what, this is the real deal or it's not. I'll either wait for the ER evaluation or this is the real deal, and they will start driving in and get their team to start driving in. We've got some of the docs are doing this. We've got door to groin puncture times of 30 minutes. Let's stop talking about door to TPA time. This is door to groin puncture doing some of these things. But from an EMS perspective, I mean, you saw what Charlie mentioned about hospitals just self-attesting. Yes, I'm a stroke center. That makes me a little uncomfortable because I'm driving past hospitals to go to another hospital that says they're going to do what they're going to do, but they may not have any sort of third-party attestation. That puts me in an uncomfortable position where I got to do the third-party attestation. And this is actually what led to the Florida Stroke Registry. Because out of South Florida, we said, you know what? I need to know, hospitals, if you're doing what you're saying you're doing, so I need to see the data. And this is actually a dashboard. I think this one's actually from Broward County. We don't identify the hospitals, but this is percent of the people arriving who get endovascular therapy. And you see enormous differences. You got one at 3% and one at 26%. Look at that entire range. That's an enormous range. And then you've got the averages down there. So now I can look at this and go to the hospital that's at 3% and say, why are you guys only at 3%? Let's take a look at that. Let's make sure you're doing what you're supposed to be doing. I think accountability, both on the side of the hospitals and on the side of EMS, is very important. Here's the median door to groin time for those that receive endovascular therapy. Same thing. This is not to punish one hospital or the other, but this is to look at these guys that are down in the 40 minutes and say, why are you guys so good? Let's share that. We have to stop thinking that there's some market share or some secret that we have that you can't share with our hospital colleagues. Because you know what? You may be the patient and you might not go to your hospital when you have a stroke. Don't you want them to be as good as your hospital is? And that's kind of the key thing here. So what is the best stroke model for EMS patients? And it's the fastest endovascular therapy. That's my personal belief. Because I think this is the #1 key driver on really changing the outcome of this disease. Spoken hub versus CSC, I think the evidence clearly shows if you're within 20 miles, you always go to comprehensive. If you're over 20 miles, it's not so clear. So I think there's a number of models that are starting to be developed. Do we fly them like we do in Palm Beach County? Do we have you guys, who are the interventionalists, have you travel to a non-interventional site and meet the patient to decrease the travel time? So there's a number of models being worked on that. So I don't think that part's been cleared. But within 20 miles, I think there's a lot of data now that shows that that's the right thing to do. And then what about the primary stroke centers? Do we still need them? Yeah, we still need them. We see in our county that 35 to 40% of strokes still show up by private vehicle. But, and here's the but, we need our primary stroke centers to be trained to do rapid evaluation to see who needs intervention. It's not just about who needs TPA. It's about who needs to be rapidly transferred for intervention. So here's my lessons learned. Patients' needs must always come first, even when that is politically difficult. And I gotta tell you, it was politically difficult, but they have to come first. We have to remember why healthcare exists. Use the data to drive care and measure outcomes and to hold everyone accountable, including EMS. We wanna be held accountable. Most important one is meet with CEOs one at a time. Don't do the mob thing like I did. That was a really bad move. And I'm gonna give one last disclosure because we often think of patients as some nameless, faceless stranger. But those of us who are in the field or in the position where you can make changes to the system for the betterment of the humanity that we take care of, need to understand that the patient is us and our family members. And that's why we always have to put the patients first, no matter what the business interests want to do. Thank you very much.